Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries, which this week were brought to you by our authors Shannon Marcus, Joshua Belfer, Samuel Rouleau, Catherine Berger, and Clay Smith. Okay, let's get straight into the first article, which was titled Fewer Admissions, Shorter Stays, Phenobarbital Use for Alcohol Withdrawal in the Emergency Department, out of the Journal of Academic Emergency Medicine. As anyone who works in the emergency department will know, alcohol use disorder it's a pretty major problem, and it contributes a lot to hospital visits. The estimate is that about 29% of U.S. adults will be affected by alcohol use disorder at some point. And 50% of individuals with chronic alcohol use will develop alcohol withdrawal syndrome at some point. And so this contributes heavily to emergency department visits. Now, the mainstay for treating this for quite a while now has, of course, been benzodiazepines. However, phenobarbital is making a comeback, and this is largely due to some conveniences with its pharmacokinetics. Namely, that it has kind of a long half-life and the dosing is relatively straightforward. Whereas benzodiazepines, not that the dosing is that complicated, but the pharmacokinetics are not necessarily as reliable. And I don't know, I like the weight-based approach for phenobarbital too. That just sounds like it makes more sense most of the time. Whereas benzodiazepines, I don't know, it seems a little bit less organized to me. Now, the unfortunate part about it is that we just don't have that much data on phenobarbital out there. But still, all the same, there have been a number of emergency departments and hospitals that have switched over to using phenobarb as their go-to medication for alcohol withdrawal. And so that's what this study was. This was a retrospective cohort study looking at patients with alcohol withdrawal syndrome who were treated from 2020 to 2023. They found almost 800 patients, and they wanted to compare, depending on what kind of medications they got, phenobarbital only, benzodiazepines only, or combination therapy. They were seeking to address some of the kind of holes in the literature, that is, length of stay and 30-day returns. It seems like past research has shown that 72-hour return rates are less common if you use phenobarbital, but the length of stay isn't necessarily something that we've seen it necessarily decreasing, in 30-day returns, but I don't really care about 30-day returns because the drug is way out of your system. If you're coming in within a month later at this point, then I don't think that has anything to do with the medications you got up front. Not really anyways. Now, in this study, they also excluded patients who got oral therapy, which is kind of a shame because phenobarbital is great to give orally. It actually has 100% bioavailability. So giving it PO is just as good as IV, and that's something that's great about phenobarbital. However, if you're just looking at patients who got IV therapy, then you're getting kind of a sicker population probably, because for some reason, presumably, you couldn't give them PO medications. The authors said that it would have sort of muddied their sample more to do the PO study, and that it wouldn't have been as well recorded in their medical record for some reason. But anyways, this is what we got. People getting IV therapy. And as for how much they actually got of it, while their dosing of phenobarbital in the study was really very conservative. It's a legitimate approach. Even if you look at up to date, it's one of the recommended methods, but it's still a very conservative way of dosing phenobarbital. What they did was they gave 260 milligrams and then an optional 130 milligrams. And that was the kind of upfront dose. And that's baby dosing. This is really timid dosing. I mean, so you want to dose this for ideal body weight, unless you're weighing less than ideal body weight, then for gross body weight. And so let's say they're treating someone who's about, let's just say their ideal body weight is 70 kilograms. That's not a ridiculous thing. And so if you ideally gave also that extra 130 dose, and you're getting 390 milligrams up front. This is just about around 5 milligrams per kg if your ideal body weight is 70 kilos. Again, only if you gave that extra dose, which is pretty conservative dose. You could easily give double that, which is also a very legitimate way to treat these patients, and just give upfront, get an an ideal body weight for this patient and give 10 milligrams per kg boom loading dose. And that's a good way to do it too. And I think you're going to have less trouble, probably shorter lengths of stay by just giving a larger upfront dose. So I think if you're a little bit more aggressive, and these are safe doses, by the way, you can give this is not a dangerous dose to give these patients. This is something that you would load someone up on if they were, say, if you were using phenobarbital as an anti-epileptic, you could easily load them with 10 per kg, and this is not something that's going to knock out your patient. This is a safe dose. And this is a dosing strategy, which is, again, even recommended on UpToDate. So this is something that you can see in certain places. If you look at, Josh Farkas, the Internet Book of Critical Care, they talk about dosing about in this method as well. And they recommend a ceiling dose of somewhere between 20 milligrams per kg and 30 milligrams per kg, which starts to get into pretty high doses. And you've got to question whether or not you've got your diagnosis right. Anyways, all to say that they were using pretty conservative doses here and that you could go harder if you wanted to. All the same, they found that phenobarb monotherapy was associated with a significantly lower hospital admission rate, 52% versus 74%, as well as shorter ED lengths of stay, about 6 hours versus 7 hours-ish. So a little bit shorter, but it was significant. As for the return visits, at 72 hours and 30 days, there was not a significant difference between the treatment groups overall. And this leaves us with phenobarbital, at least as monotherapy, looking pretty good. The combination therapy did not seem to fare necessarily better, so you're probably better off just picking benzodiazepines or phenobarbital and not trying to mix it up. Now, I think that the actual use of phenobarbital is really probably going to depend on your hospital's protocols. Most people likely have an order set that's going to give you, alcohol withdrawal syndrome treatment, and you just click it. The nurses probably do CWAS, which is unfortunate. They could just be doing RAS scores and saving everybody the time, but that's another discussion from another paper that we covered a while ago. Anyways, all to say that you're probably going to do whatever your hospital does, but if you want to start switching over to phenobarbital, it's a very legitimate strategy, and I think that the dosing is straightforward. It's weight-based. You have kind of cutoffs that you can look at. You have a place to start and an upper limit. I think that's really nicely organized treatment for something. So in a spoonful, I try not to put too much weight on retrospective studies, but they are good for something. They're proof that people are out there doing this approach, and so that really legitimizes it. It's not a great argument for picking phenobarbital necessarily over benzodiazepines, but that said, from this study, it seems there was association between using phenobarbital and shorter lengths of stay as well as fewer admissions, so there's something. And then we skip over to the fifth article, which was titled High Risk and Low Incidence Diseases, Cyanotic Critical Congenital Heart Disease, out of the American Journal of Emergency Medicine. Now, this is a summary, so of course the last author is Britt Long. He seems to author like every review we cover. Now, for anyone who sees pediatric patients, one of the most feared presentations for the child to probably get carried through your doors is some kind of cyanotic congenital heart disease, of which there are a few, and you can remember either the 5 T's as well as a few others, or you can just kind of remember that anything that's going to have right to left shunting to a significant degree is probably going to make your patient cyanotic. So we've got truncus arteriosus, we've got dextrotransposition of the great arteries, we've got tricuspid atresia, we've got tetralogy of Fallot, total anomalous pulmonary venous return, as well as hypoplastic left heart syndrome, Ebstein's anomaly, and critical pulmonary stenosis. These are pretty much all of the congenital heart diseases which are going to cause cyanosis when things are not going very well. Some lesions can be mild, and so they might not get picked up at first, although the majority of lesions are going to be picked up on prenatal screening. However, if they're more mild, then over the next couple of weeks, as that PDA closes, you might have them coming in real crisis. And it's estimated that about 25% of cases are not discovered after the initial hospital discharge at birth. And so this is definitely something that does happen. These kids do come in with these problems. Differentiating a congenital heart disease problem from sepsis or a pulmonary pathology isn't always very straightforward. So you're going to want to try to keep your differential broad, but there are a few things that can kind of tick you off that, hey, maybe this is a congenital heart disease. Now, the kind of classic findings that would think, hey, this is a heart problem, is that they do not respond to supplemental oxygen. Again, because their lungs are working great, they're just having shunting. They have tachypnea without increased work of breathing, so-called silent tachypnea. They have the presence of a murmur, which of course is going to make you think that it's a heart problem, and hepatomegaly, more than 2 centimeters below the right costal margin. Besides that, any child that has dysmorphic features is also more likely to have some kind of congenital heart disease, so just keep that in mind as well. The primary workup is going to be broad. As I said, don't anchor on this, but always have it in mind. In terms of being a little bit more specific towards heart disease, you can order BNP testing, which seems to be about 100% sensitive and 98% specific, apparently, in these young infants for differentiating cardiac versus pulmonary causes of hypoxia. Otherwise, you'll also want to do an ECG, a chest x-ray, and an echo. Remember to keep your differential broad, though. You will feel slightly reassured to know that most of these congenital anomalies are not associated with a significant increase in the rate of arrhythmias, except for Epstein's anomaly, which is particularly associated with some dysrhythmias, but otherwise you're probably pretty good. Now, as for treating these young little kiddos, critically ill hypoxic infants may benefit from prostaglandin E1 if they're still within the first couple of weeks of life. Now, the major side effects of this are going to be apnea and hypotension. So some are going to advocate for intubation of all infants just in case they do get this apnea. But now you're going to want to have help in the room for this, definitely, because these are sick kids who you're going to give medications which could cause apnea, hypotension. You're going to switch them over to positive pressure ventilation in someone who's already got a congenital heart disease that's decompensated. These are high risk intubations. These are sick kids. Then there's another group of kids. These are often going to be older than just a couple of weeks, but still could be just a couple of weeks. And these are going to be kids with TET spells or stress-induced hypoxia in children who have tetralogy of Fallot. Now, what you're going to want to do is decrease pulmonary vascular resistance and increase systemic vascular resistance with knees to chest supplemental oxygen, trying to give them some fentanyl to calm them down, and all of this should improve their hypoxia. Overall, that's a broad review of critically ill congenital heart disease patients. You're just going to want to always keep this in mind in the critically ill infant who's coming in hypoxic. Often they're going to be cyanotic, but call for help early. Get those cardiologists involved. And otherwise, there's not that many specific treatments. Just be judicious with your fluids, and you can start prostaglandin, but be warned that you may have to intubate. In a spoonful, that was a review of congenital heart disease patients. And that's all 5 articles from this week. Let's do a quick wrap up of everything we talked about. From the first article, we did a retrospective study which covered phenobarbital for alcohol withdrawal syndrome, and we found that it was associated with shorter lengths of stay and fewer hospital admissions. And then finally, the 5th article, which was congenital heart defects, which are scary, but the approach to them doesn't have to be. Now, if you're hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What were those articles about that you missed? Well, we covered the basic and advanced life support AHA update guidelines, as well as doing a deeper dive into Andromeda Shock 2. Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Again, our goal here is for you to keep up the easy way through spoon feeding. Thank you.